finish up on that, Chris Donner sent a link around demonstrated that BMAC is trademarked, it looks like. So to that question, it is, look at the details here. So it is trademarked, but clearly that's by Harvest Technologies, with whom I think none of us have any formal relationships. So clearly there's some controversy still there, and a lot of gray zone in definitions, but I think we all agree it's critically important that we define these cell populations we use. And one of the things maybe can come out in this discussion as we move along today is, how do we define the cell population? That is, what are the markers we need to identify, markers of purity or potency, or are there any sentinel markers we can eventually measure? I think we don't have the answers today, but until we can get to the point of being able to really characterize these cell preparations, it makes it difficult to interpret the literature. So why don't we go ahead to our second question? We have a total of 8 slides with various questions to kind of frame a discussion here. And so as you see here, next question is, what are the current reasonable expectations for point of care therapies, in particular like a bone marrow aspirate concentrator, call it cell therapy, call it bone marrow cells. In particular, we'd ask the panelists to think about and address, how are these point of care bone marrow cells different than, say, cells derived from adipose tissue, such as the stromal vascular fraction? Or how do these point of care, marrow in particular, preparations, how do they differ from maybe next generation preparations, if you will, such as induced pluripotent stem cells? What is the opportunities here? What are the expectations we can tell our patients? And lastly, importantly for the clinicians, what are the clinical settings where we think it is appropriate to use some of these emerging biologic therapies? Maybe, Nicolas, we can ask you to start with your experience in seeing patients in Cleveland. Maybe I even start with the last part. What are the clinical settings where it's appropriate to use some of these cell therapy approaches?
Thank you, Scott. So I think that the first thing to address is that we still have gaps in the treatment armamentarium for many of the conditions that we treat on a daily basis, right? If we focus in osteoarthritis, we know that there is a subset of patients that have failed all the reasonable conservative treatments that we have. And they worked on weight management, they work with physical therapy, they've done everything that that we have available. And they still are experiencing pain, and they might not be ready for surgery. So there is a gap in treatment that we don't have anything to offer to those patients, or there's very little that has proven clinical efficacy. So that opens the door for exploring new treatments. And I think that's probably one of the areas that we can all agree that has been one of the engines behind the rise of biological therapies, in a way of giving some hope that there might be something that might help them in an attempt to avoid the next step, that would be to proceed with surgery. So I think if you're looking in the musculoskeletal arena, either osteoarthritis, either a vascular necrosis, many of the tendinopathies that we treat, there are different phases or different time points during the treatment of those conditions that we don't have anything to offer, or very little, and that's kind of the gap and where they've increased. And just the only link that I would highlight that I think that links to the first question is that what's currently available at point of care, it's mainly based on autologous heterogeneous formulations out of the tissues that we have readily available to use, either bone marrow for BMAC, blood for PRP, fat for doing any kind of fat processing that we can do, and we can discuss about regulatory aspects of that. So when it comes to the quality release criteria, how we're going to be measuring the potency, or what's the minimum things that we should be measuring to assess that what we're providing is what we intend to provide as a treatment, all those are still questions that we're still, I think, trying to figure out.
Well, thank you. That's a great place, a great start. That's helpful. Iain, in your experience seeing patients in the UK, kind of same question. What do you tell patients as far as expectations when using a cell therapy approach, such as you may start with the simple bone marrow concentrate?
Yeah, well, moving on that setting, if we're getting at what are these settings where it's appropriate, I think Chris Latterman presented a really sensible approach last year at a webinar, and he was saying that, and this I guess applies to all of these emerging biologics, is that he split it into 3 settings. Said, where you have undisputed level 1 evidence, he felt it was reasonable to use, a treatment with this undisputed level 1 evidence. Anyone could use that within any of their treatment algorithms. Where there was less or disputed level 1 evidence, or level 2 or level 3 evidence, then it could be used within a treatment algorithm as an alternative, but not at the expense of evidence-based treatments. And I think that's the key thing, is where we have these new treatments, if we are using them and they don't have evidence, we shouldn't be using these. We shouldn't be denying patients access to treatments that do have an evidence base. And then finally, where there's anecdotal evidence, he suggested that in that setting, really, that should only be done as part of a clinical trial protocol, and obviously requires some kind of research infrastructure. So that's the kind of the logic I have in my head, and try to stratify that to any of these emerging biologics.
One of the challenges I find is some of these biologics that are not covered by insurance. The patient has a cost outlay. A challenge there is explaining to the patient that there is some variability in outcome. These things, the degree of relief, the duration of relief can be variable. At the same time, you want the patient, you want to maintain some hope for the patient and some optimism. So how do you balance that discussion with the patient, cost versus maintaining hope? But at the same time, you need to give the patient realistic expectations. So if in fact this, they don't have a great result, they were at least informed up front. Maybe Iain can take that, or even Dr. Joe from the experience in Korea.
No, I think you're absolutely right. It's just about being as transparent as we can with the best available evidence. And we can just provide that information to our patients along with the cost and any adverse effects, and then allow the patients to make their decision, us supporting them with the best available evidence and information.
Chris, in South Korea, what is the payer mix, and what is the status as far as insurance payment for things like a point of care, a bone marrow aspirate?
In Korea, so point of care is like some kind of point of care. It's like BMAC, and is only approved in some portion of patients by insurance. And the PRP, is covered only for the lateral epicondylitis, and others are not covered. I mean, the rotator cuff and knee OA is not covered for PRP. And the other thing, SBF and stem cells are not allowed to commercially use. So I think it's we have no solid evidence or confidence that any biologic therapy could make any structural regeneration, because the patients here, stem cells or some kind of advanced cell therapy, they not only think about the pain relief or function improvement, most of people think that that kind of cell therapy could change my destroyed knee or destroyed shoulder. So it is important to share the current expectations and concerns with patients. So with no solid evidence and confidences, so what it should have to do right now is to have what is current expectations. For me, I could divide 3 kind of stage. It's like a point of care, just like BMAC and SVF. I think this is just for pain, but no regeneration. And stem cells, which I have a little experience for that. That could be for relieve pain and quite good improvement in function with VS, some grade of regeneration of degenerate tissue. And so next level, next stage cells like iPS and other cells, I'm not sure, but it probably be very cost very expensive money, and it should have a kind of adequate regeneration potential, but I'm not sure. But this is, I think, what we have. So we have to share with this information patients and let the patients decide what to do that.
And you make a very important point. I try to make the distinction for patients between symptom modification and structure modification. That is, many of these therapies can treat symptoms to varying degrees, but we have not much data to support that they are truly structure modifying, that is, they can regenerate tissue. Now, that said, in centers where there's the ability to perhaps do cell sorting and culture expansion, in fact, there is some data demonstrating, as you, and some of your nice data and others, demonstrating that there is some potential for tissue regeneration. So it's challenging. I think that's a challenge for patients, but patients do come in with this expectation, unrealistic often, that, you know, these cells are going to regenerate tissue, as you say, my destroyed knee or my destroyed shoulder, which is, you know, largely not the case. So I think part of our job educating patients. Scott Bruder, on the other part of this question here, asks about distinguishing, you know, our point of care approaches from, say, iPSCs, induced pluripotent stem cells. We know there are no currently FDA approved iPSC treatments, of course. What are your thoughts on the regulatory environment related to that, to induce pluripotent stem cells?
Well, I think, as you said, there's nothing that's been approved in the US today. I think as long as there is a therapeutic intervention like iPS cells, like gene modified cells, like culture expanded cells, whether they're derived from bone marrow, from adipose tissue, or from muscle, or from any other source, even amniotic fluid or birth tissue products, those therapies are appropriate to evaluate when performed under the auspices of an IND regulated study that's registered at the FDA. You as clinicians can't sell that product. You can't sell the product to the patient, and you can't sell the product to patients that are not involved in the study. But I think that undertaking those appropriately rigorous phase 1, 2, and 3 studies is a laudable goal, but requires lots and lots of money. It's going to be at least $100 million to get anything like that to market from start. So that's why companies have taken a shorter approach with 510K cleared products that they can get cleared. But the problem is they don't have the level 1 evidence as we see in the sidebar here.
Right. Yep. Thank you. Why don't we move on?